Kicking off this forum today is our keynote speaker, Dr. Rene Stolwyk. Rene is a senior lecturer and clinical neuropsychologist, Monash Institute of Cognitive and Clinical Neurosciences School of Psychological Sciences, Monash University. And today, Dr. Stolwyk is presenting on neuropsychology and the role of the neuropsychologist in the assessment and management of cognitive impairment in relation to dementia, stroke, and acquired brain injury. On conclusion of his presentation, there'll be 10 minutes for questions. So please give Dr. Stolwyk a warm welcome.
Okay, hi everyone. So my name's Rene, and yes, so I'm going to talk today about some common neurological disorders, and I'm going to be focusing on how those neurological disorders impact on cognitive function, and I'll talk about what cognitive function is very, very soon. So I'll talk for about 20 minutes, and then we'll have 10 minutes for questions. So hopefully I won't talk for too long. We'll have some time for a bit of interaction. So what we'll cover today is what is neuropsychology, so what I do and how that might apply to the people that you care for. We're going to get into a little bit of information about what the crux of neuropsychology is, so brain-behaviour relationships. What parts of the brain do what, and that might help make sense to you guys about how the people you care for how their cognition might be affected. And there are lots of different neurological conditions. Oh, thank you. Today I'm just going to talk about a few, and I'm really going to just provide a very basic introduction to some of these conditions. I'll talk about stroke, which is my area of expertise. We'll cover Parkinson's disease and also one type of dementia, which is called Alzheimer's disease. So we'll cover those. Once we talk about those, we'll also then briefly touch on management and how we manage the different cognitive difficulties as well. So I hope that sounds okay to you guys. Very good. Okay. So what is clinical neuropsychology? Well, as I just mentioned, our expertise is really understanding what parts of the brain do what, particularly around what we call cognitive functions. So cognitive functions is just a fancy name really for thinking skills. So it's things like memory, concentration, problem solving, language, visual perception, and things like that. So those key kind of thinking skills that your brain is responsible for. And so how we can help someone with a neurological condition, obviously a lot of these neurological conditions, they affect the brain, so they affect thinking skills. And so what we can do is really help with identifying and characterising changes to thinking skills in those people. Because sometimes it's not really that easy, and I don't know if you've had this experience, understanding, well, has someone's memory changed or has it not? Are they just a bit tired? Has there been a significant change to someone's cognitive functions, whether it be memory or language or problem solving? And what might be underlying that? And is it getting better? Is it getting worse? Is it staying the same? We have the expertise to really help characterise and identify those cognitive difficulties. And that can be helpful. So, for example, if someone has a stroke, they'll often come to me and go, look, I think my thinking skills aren't quite where they should be. Can you help me understand, have I changed or have I not? That can help in terms of managing those cognitive difficulties long term. It can also help, for example, in the case of Alzheimer's disease, where we can very sensitively pick up on early changes in people, and that can help with diagnosis. So that's where neuropsychologists are often involved with, at the assessment side of things, to initially detect and diagnose various disorders like Alzheimer's disease, but also later on helping to manage and rehabilitate in the case of things like brain injury, so something like stroke. So we do some assessment to identify and rehabilitation to help kind of manage those difficulties. So that's the two kind of main jobs we focus on. So that's what neuropsychology is, and a big part of what we do, as I said, is we know what parts of the brain do what. And going through all the brain functions is that's like a 1-week workshop, so I'm not going to go through it all today. So I thought I'll just pick two parts of the brain and highlight what parts of those brain parts do. I think maybe just two main messages or something you could take away from today. So the brain is organised according to lobes. So you'll see here we've got we'll try using this thing. So we've got the frontal lobe here, we've got the temporal lobe, the occipital lobe and the parietal lobe. The two I'm going to cover today is just the frontal and the temporal lobes, because I think it's probably the most relevant. And there's going to be a test soon, so pay attention, okay? So when we think about the temporal lobe, a major function of the temporal lobe is that it houses what's called the hippocampus, and that's very important for learning and memory, okay? So it helps you encode information and hold it over time so you can retrieve it later. So think temporal lobe, think memory, okay? Also talk about the frontal lobe as well. The frontal lobe has, there's lots of functions. I'll just tell you about two major ones. The back of the frontal lobe is the motor cortex. So when I want to move my arm or move my leg or any body part, it's that motor cortex that enables me to do that. I tell my arm to move, it's that motor cortex that helps me move any parts of my body. So that's one major function of the frontal lobe. A really important part of the frontal lobe too, particularly the front part of the frontal lobe, is responsible for those high-level cognitive functions. It's what we call executive functions, but it's a bit of a weird term. But it really refers to high-level thinking skills like planning, so being able to plan your day, organise lots of different tasks, problem solve, so working through really complex problems. When you're doing that, that's the frontal part of your brain working over time. Okay? That's all I'm going to talk about today. So temporal lobe memory, frontal lobe, movement, and high-level problem solving. Try and see if you can remember that. Use your temporal lobes to try and remember that if you can. Another really important way to understand what different parts of the brain do is the left part of the brain versus the right part of the brain. Okay? And there's two major distinctions between the left part of the brain and the right part of the brain. The left part of the brain is where language is organised. So your ability to produce speech is in the left part of the brain, the front part of the brain, and your ability to understand language is on the left side of the brain as well. Okay, so when people have damage to their left side of the brain, depending where it is in that left side of the brain, they can have difficulty producing language and understanding language. Whereas the right side of the brain is particularly involved in understanding visual information. So things like navigating from place to place, recognising faces, all visual information is on that right side of the brain. Okay? So when you think left and right, you think left for language, right for visual stuff. The other important differentiation between left and right is what side of the body it controls. So the left side of the body controls one side of, the left side of the brain controls one side of the body. Anyone want to have a guess about what that side might be? Yeah, I don't know how nature created that. It's very confusing. But yeah, the left side of the brain controls the right side of the body, right side of the brain controls the left side of the body, just to confuse us and make our lives difficult. So those are the major distinctions we're going to talk about today, and I want you to try and remember that information. We'll go through it again later. So that's some basics on brain behaviour relationships, okay? And we'll apply that now to stroke, okay? So I'll first talk about what stroke is. And stroke really refers to any disruption to brain function because it's not getting enough blood to a part of that brain. Okay, so there's some disruption to the blood supply of the brain, and because of that, those brain cells aren't getting what they need. So what does blood supply to the brain? What are some key things that the brain needs that blood gives it? Oxygen, yeah, and nutrients, sugar particularly, glucose, energy, yeah. So when blood doesn't get to the brain, those brain cells get damaged and can die. There are two types of stroke, and that's helpful to understand in terms of there's the more common type of stroke, and that's called an ischemic stroke. Okay, an ischemic stroke is what's characterised in this blue here. Okay, and that refers to when an artery, which is a major blood vessel to the brain, it gets blocked for some reason. Often that's a blood clot or something in the blood that actually clots that artery, and like a dirt in a hose pipe, it means that blood can't get through to that part of the brain. And that's basically what an ischemic stroke is. There's a blockage to the artery, and it means that a part of the brain doesn't get the blood it needs. And there's lots of different arteries throughout the brain, and depending on which artery is blocked, will decide on what part of the brain is damaged and then what are the signs and symptoms. And that's probably something that's really obvious with stroke, is that you put 100 stroke survivors in a room, they all have different symptoms, and that's because a different artery has been blocked and a different part of their brain has been damaged. So you can't just assume that everyone with stroke has got the same difficulties. So an ischemic stroke is the most common. The less common type of stroke is what's called a hemorrhagic stroke. So that is, instead of a blockage in the artery, there's actually been a rupture to the artery. So blood is actually leaking out of the artery and is not getting to the part of the brain that it needs to. Okay. And a major cause of a hemorrhagic stroke, or the most major cause, is due to what's called an aneurysm. Has anyone heard of what an aneurysm, or want to have a go at explaining what an aneurysm is? Yeah. Exactly. Yep. So it's a weakening in the artery wall, and I don't know if you've ever had a dodgy car and a dodgy car tyre, but when that pressure pushes on that weakened wall, it can balloon out. And actually, an aneurysm in itself is not necessarily a bad thing. Actually, lots of people in this room, including me, we could have an aneurysm and we could live our days quite happily. It's only a problem when that aneurysm bursts, often due to high blood pressure. That's when the problem can occur. So hemorrhagic stroke, due to often burst aneurysms and ischemic stroke. So thinking about neuropsychology, often the physical signs of stroke are quite well recognised. And particularly when you first, I don't know if you're familiar with the FAST acronym, face, arm, speech, time to call an ambulance. We often recognise the motor aspects of stroke quite early. But what we're beginning to understand in the last 15 to 20 years is that there are some thinking changes associated with stroke. And actually, the majority of people with stroke will have some kind of change to their thinking skills. And of course, that's going to be different according to each stroke patient. So a little bit of a test now. So if you think about someone that's had a stroke and it's in their right temporal lobe, what kind of cognitive or thinking difficulties do you think they might experience? So temporal lobe is responsible for memory, and the right side of the brain is responsible for visual stuff. Yeah, so a really common complaint for people that have had a right temporal stroke is they have real trouble learning and recognising faces. They get lost all the time. They can't remember new routes. So they often experience those kind of difficulties. What about a left frontal stroke? What kind of cognitive difficulties do you think you might experience? Yep, so language will be one of them. Yep, so actually producing. Not so much memory, that's more of a left temporal lobe. Yeah. Yeah, movement. So what side of their body will they have difficulty moving? Yeah, the right side. Yep. And particularly if it's in the frontal part of the brain, what will they have a lot of difficulties with? Yeah, not so much memory, but it's that organisation. So it's that planning, organising, problem solving. Yeah. So that's just a bit of an example of how a different stroke can cause different cognitive difficulties. And that's where a neuropsychologist can be really helpful to identify those difficulties. In terms of recovery, so most people after stroke, in those days, weeks, months, or even years after a stroke, they actually do experience improvement of any kind of cognitive difficulty. Part of that is due to spontaneous brain recovery. We now know that a brain does recover to a degree. But we also know that in engaging in rehabilitation, it really does also extend that recovery. So most people would expect some kind of improvement. If you're noticing as carers that that's going the other way, that there's actually a decline in cognitive function after stroke, and that's progressive and it's continuing to decline, something else might be going on. And there's a type of dementia called vascular dementia, where there's a progressive deterioration of the vascular supply to the brain, and that causes progressive cognitive decline over time and brain pathology. So that's something to watch out for carers. So if you're seeing this decline over time, you want to be getting that checked out. Yeah. Okay. Also, things to be looking for too is something that's really commonly missed and not diagnosed: mood disorders after stroke. So we know about a third of people with stroke will experience a mood disorder at some point during their recovery, and we know that the majority of those people won't receive adequate assessment and intervention. And we've got some really effective treatments for depression these days, both pharmaceutical and also non-pharmaceutical. So that's something, again, as carers to be looking out for and to be addressing if you can. And also there can be changes in behaviour. And I'm not going to talk too much about behaviour today because you've got a wonderful presentation coming up from Margaret in the back there about behaviours of concern, particularly in dementia. But I just want you to note that that can happen after stroke as well. That's something you want to be looking for. So actually we might leave questions to the end, so write some questions if you have any questions about stroke. I'm more than happy to talk about that. The next thing I'll just briefly touch on is another disorder called Parkinson's disease. Anyone caring for someone or anyone know anyone with Parkinson's disease? Yeah? Okay. So let's talk a little bit about what Parkinson's disease is. And it's an incredibly challenging disorder to live with, and affects lots of different functions. And surprising because it's only a tiny part of the brain that's affected in Parkinson's disease. It's a tiny part of the brain in Parkinson's disease called the substantia nigra. Tiny part of the brain, right in the centre part of the brain, and that produces what's called dopamine. Okay? And that part of the brain dies, which means that you don't produce dopamine. And dopamine is really, really important. It's the juice, it's the petrol that gets the brain, that allows the brain to kind of run, particularly for movement and motor function. But we're also beginning to understand that's important for cognitive functions as well. So we've known about the motor signs of Parkinson's disease for a long time. So tremors, rigidity, stooping posture, movement becomes slow and it gets smaller. So you can often see handwriting getting smaller. Their voices get softer as the disease progresses. So the motor signs are quite well recognised, and it's only really been in the last 15 to 20 years we've understood that thinking skills, so cognitive skills, can be affected in Parkinson's disease as well. And unlike stroke, you get quite a similar profile of cognitive difficulties across people with Parkinson's disease. They're generally mild to moderate, and they don't progress. They don't get worse and worse really quickly and get really severe quickly. They tend to remain mild to moderate for most people with Parkinson's disease. But what they do experience, and even mild difficulties, can actually cause quite significant distress and problems for people. And what they experience is slowed speed of thinking, so it takes them longer to do cognitive tasks. Reduced attention, so they have difficulties focusing their attention and holding their attention over time, so they can lose concentration quite quickly. It can affect that frontal lobe function, so problem solving, organisation, planning can become more difficult, and that can impact on memory as well. So they can experience these cognitive difficulties, and again, it's important to recognise, assess and understand and put some management strategies in place to help manage those difficulties. It's important to recognise as well that there's a minority of people with Parkinson's disease where those cognitive difficulties don't remain in the mild to kind of moderate category. And there's a small proportion that actually experience a progressive decline in cognitive function over time. So they get worse quite quickly. Again, as a carer, that's something you need to be looking out for because it might suggest that they might have something called Parkinson's disease dementia, another type of dementia. As I said, it's the minority of patients, but it's something you need to be looking out for. And often the patient themselves may not recognise it, so it's up to family, friends, carers to recognise that, hey, their thinking skills are deteriorating over time. And again, with Parkinson's disease, 40% of them will actually experience a major depressive episode. And there's been some really interesting research showing that actually depression might actually manifest before some of the motor symptoms. It's almost it's one of these potentially predictive signs and symptoms of Parkinson's disease. So again, something you need to be looking out for. And again, behaviours of concern as well, particularly in those with the more kind of moderate to severe cognitive difficulties. That brings us to the last condition I'll talk about today, which is Alzheimer's disease. So in Alzheimer's disease, so I think something important to note is that Alzheimer's disease is just one type of dementia, okay? So dementia is a syndrome, and it really refers to any kind of progressive cognitive decline due to some kind of brain pathology, okay? And there's different types of brain pathologies which will determine what type of dementia a person will have. And by far the most common type of dementia is Alzheimer's disease, okay? So Alzheimer's disease is caused by these horrible amyloid plaques and tangles that manifest within certain parts of the brain and actually they impair cell functioning and end up leading to cell death, okay? So what we find is as these plaques and these tangles generally manifest in certain parts of the brain before others. And we find that these plaques and tangles generally start off in the temporal lobes. Yeah. So again, testing your memory here. What do you think might be some of the early signs and symptoms of Alzheimer's disease? What's one of the first things to be affected because these plaques and tangles end up in the temporal lobes first? Memory. Yeah, temporal lobes, memory. So you can kind of piece the puzzle together a little bit and understand why memory is one of the first things to be affected in Alzheimer's disease. It's because these plaques and tangles hit the temporal lobes first. And as the disease progresses, these plaques and tangles actually spread throughout the brain. They start then heading to their language centres, so it starts affecting their understanding and their expression of language. It starts to hit that front part of the brain, so it impacts on their problem-solving skills, planning, organising. And then as the disease progresses, it really just becomes more diffuse, and you experience global brain dysfunction over time. So it becomes very specific, and unfortunately it just spreads. So how does that look? So often in the early stage of the disease, so because it's more around memory, people have difficulties, things like remembering appointments, remembering new people's names. They might have a little bit of difficulty remembering new routes to different places. As it becomes a little bit more moderate, they might start having more difficulties with things like finding their belongings or remembering things that they knew before. So rather than learning new information, they have trouble remembering more and more kind of established information. And as the disease progresses, it starts to impact on those more basic skills. So things like dressing themselves, grooming themselves, maintaining basic hobbies, right through to, in the end stages there, even those basic functions of eating, talking, walking become affected. So, and that's the really confronting part of the disease, where even those basic self-care functions become affected. Okay. So those are the three kind of syndromes I briefly covered today. I want to talk a little bit about, or if those cognitive difficulties are there, what can you kind of, what's a good kind of plan of attack to how to manage them, okay? And the first plan of attack is really to understand the problem. I think a lot of, in the cases I've seen, some people try to jump into getting a management plan in place before they've really understood the problem at hand. So the first thing you need to understand is, well, is this a medical issue? So for example, I've had some clients and their family that have been really worried that their loved one has dementia, and it hasn't been the case at all. They've actually had, I had one case where someone just had really problems with their nutrition. They had really low B vitamins and a whole range of nutritional issues, and that can actually look like a decline in cognition over time. I've had some people with just a urinary tract infection. Okay, and that can, and particularly in older people, that can really impact on cognition and lead to a delirium. I've also had some people that are so severely depressed, again it looks like, and there's been just a worsening of depression over time, that it can again look like dementia, and they've been misdiagnosed with dementia. Really they've got depression. Or in actual case, you might find through a really good assessment that it is actually a neurological issue. It might be Alzheimer's disease or Parkinson's disease or a stroke or whatever. So you need to understand the problem first and a good starting point is obviously with your GP, and then obviously referral to more specialised services. So it might be a neurologist, might be a psychiatrist. If it's really unclear, you might see a neuropsychiatrist when they're not sure whether it's neurological or psychiatric. And there are a number of services across Victoria, and most health bodies will have what we call CADMS teams, and they're a specialised multidisciplinary service that specialise in the assessment and the management of dementia. So that's really a gold standard, I think, in terms of assessment and management of dementia is going through a CADMS team. Another important thing too, so once you've understood the problem, education is powerful, and there's some fantastic resources available. For stroke, Enable Me was launched, I think last year or the year before. That's a fantastic resource for stroke survivors in terms of education, support. We've got Parkinson's Victoria as well, really vocal group, a fantastic group that look at managing and supporting people with Parkinson's disease and their carers, and also Alzheimer's Australia as well, which I'll let Margaret probably talk about very, very soon. And if there are significant cognitive difficulties, you might come across someone like me, a neuropsychologist. And again, what we'll do first is probably assess and understand what actually, when we get to the crux of it, what kind of cognitive difficulties the person does have. And once we've done that, we'll start working on managing it, okay? And as neuropsychologists, what we focus, there's actually a lot of discussion at the moment about the best way to improve cognitive functions after some kind of brain injury. For a long time, people have been suggesting that doing a lot of brain training might help. Have you guys come across any of those brain training, like lumosity and...
We do clapping.
Clapping?
Yeah, clapping to a rhythm.
Okay. Yeah. So we'll be looking at, that's a big part of my research project, is looking at those computer brain training, which uses the principle of the brain as a muscle, and the more you do kind of memory tasks on a computer, the more strong your memory will get. And unfortunately, what we've been finding over the last few years is that doesn't work so well. We're finding that the people get really good at the memory games on the computer, but that's not translating to remembering their shopping or remembering their grandkids' names or whatever. It's not translating particularly well. So as neuropsychologists, we actually focus more on what we call compensation. So that's working with your memory difficulty and trying to minimise the impact of that memory difficulty. Yeah, so it's training a person on how to use external memory aids like a diary or a memory station, or more internal memory strategies. And we're finding that's a lot more effective in terms of actually improving everyday memory function. So at this point in our research, we're less enthused about these computer brain training methods and more enthused about actually practical everyday strategies to manage your memory difficulties. And for those people who are interested, we're actually running a memory skills group that teaches those strategies at the Monash Centre. How am I going for time, Kate? I think I'm... Yeah? I think I only have... Oh no, there we go. I'm done anyway. Just a quick mess. I'm not going to talk about managing behaviour because Margaret's going to cover that. The last point is just around mood impairments as well. Again, just always be, as carers, it'd be great if you could be monitoring that because it's just so sad to see how often it's not diagnosed, and it's really frustrating because we do have very effective treatments these days. And they generally come in two main kind of classifications. There's pharmaceutical medications, which are effective, but also more psychological options as well. So cognitive behavioural therapy is a psychological technique that's shown to be very effective, particularly for depression and anxiety. And what I've seen in clinical practice is that combination of pharmaceutical and psychological therapy is really effective in terms of treating anxiety and depression. And the research backs that up as well. So there's some really good management options for you guys as well. Okay.
Can we give a big hand to Dr.
Thanks, everybody.
Thank you very much for coming today.
No worries.
Thank you.
My pleasure.
Thanks
Thanks
so
guys.
much.